My name is Bruce Struminger, and I am with Project ECHO at the University of New Mexico, and it's my pleasure to be the first person to welcome you to today's COVID-19 vaccination, Building Global Capacity, Vaccination Strategies Learning Session. Next slide. I have just a few housekeeping items I want to review before we dive into the main part of today's session. First is that we have interpretation available in French and Spanish. You can access that by clicking on the small globe at the bottom right of the Zoom toolbar, the interpretation button. Next slide. You can then choose either French or Spanish. And if you would like to hear the interpreted language only, click mute original audio at the bottom, and you will only hear the interpretation. Next slide. We're really looking forward to your questions and comments today. Please put those in the Q&A feature just to the left of the interpretation button, also at the bottom of the Zoom toolbar. If you have any questions regarding IT or logistics or the certificate of attendance, please put those in the chat. We'll be monitoring both the Q&A and the chat, and we'll try to help you out as best we can. Next slide. Today's session is being recorded, and your attendance is consent to be recorded. The recordings will be shared after the session in about a day or two. The recordings in English and French and Spanish, and we'll share a link in the chat to the website where those are archived. We're also offering a certificate of attendance through the University of New Mexico via a link in the chat at the end of the session. After completing a short 2 to 3 minute survey, you'll be able to access that electronic certificate of attendance, and you'll have 48 hours to do that. Next slide. Just a note about data use. We just want to ensure everyone that your individual data will be de-identified and kept confidential, and the data that is shared with WHO is all de-identified, and we take data stewardship very seriously. Next slide. This series of live sessions is built to complement the Open WHO training series, 2 series, one on orientation to national deployment and vaccination planning, and the other focused on training for health workers. Today's session is in the work stream of the National Deployment and Vaccination Planning series. And we'll share links to both of those online courses with you in the chat. And with that, it's my pleasure to hand the baton to Shoshana Golden at WHO. Shoshana.
Hi, thank you so much, Bruce, and welcome to all. Next slide, please. Next slide, please. I'll be talking about our announcements and new updates. So the first announcement is that the COVID-19 vaccine introduction toolkit is available in all UN languages. So that includes English, Arabic, Chinese, French, Russian, and Spanish. When you receive the link to the slides, you'll be able to access all of those links directly. We also have an update that there is now a frequently asked questions available specifically on COVID-19 vaccination and breastfeeding. This is based on the WHO SAGE interim recommendations, and the link is available here as well. Next slide, please. I'd also like to announce that the COVID-19 Listening and Learning series that is being presented by Boost is now going to be launched on Monday, April 12th at 9 a.m. Eastern Standard Time. This will provide an opportunity for people involved in COVID-19 vaccine introduction to share their experiences, connect, and provide realistic problem-solving inputs and expertise. Next slide, please. Today, we'll be talking about COVID-19 vaccination strategies with a focus on comorbidities, pregnant women, and humanitarian settings. As always, we will then have our what's next of upcoming session topics and our question and answer component. Next slide, please. The goal for today's session is to provide an overview of key information and resources that can help countries to plan for and implement COVID-19 vaccination strategies. We have two learning objectives. The first is to explain good practices for both planning and implementing COVID-19 vaccination for people with comorbidities and for pregnant women. Our second learning objective is to provide an overview of how to plan for and implement COVID-19 vaccination in humanitarian settings. Next slide, please. I'll now turn to Joachim to walk us through a brief overview of the priority groups within the SAGE roadmap.
Thanks very much, Shoshana. It's a great pleasure to be on this webinar. So, my name is Joachim Rombach. I'm the Secretary of WHO Strategic Advisory Group of Experts, SAGE, and I give you really a very brief overview on the priority populations and then on the vaccines that we have so far reviewed, where we have issued interim recommendations on the use of these products. So next slide, please. So we actually put out in October and then revised in November a document which is called the roadmap for the prioritization of population groups for vaccination. And by COVID standards, this is already a pretty old document, but I think it's still relevant. And let me just spend 2 minutes on this. So what we did at that point in time is actually we defined priority groups for vaccination in the context of different transmission scenarios. And here you see the slide for community transmission. We also had looked at sporadic cases or actually countries that control the disease. Now, unfortunately, most countries are in community transmission. That's why I'm zooming on this here. And then looking at different stages of vaccine supply, which you see here on the left-hand side. So stage 1 is very limited vaccine, stage 2 is limited vaccine going up to, let's say, 20%, and then it's a third stage with moderate vaccine availability, which is in the range of 20 to 50% of the population. Now, what we see today is that obviously, I think most countries are still in stage 1, regretfully, but we know also that some countries have been moving through and are in different stages. And so we have prioritized populations based on some general principles and also based on distinct strategies that what we think on the public health side should be achieved in the first place. And I think most countries are really aligned with this. And so in relation to community transmission, clearly the initial focus is on the direct reduction of morbidity and mortality, as well as the maintenance of the most essential and most critical services, which are, of course, the health services in the first place. And then only at a further step is the expansion to other groups that include populations that are equally important, but maybe less critical, and then also. So this is
my apologies for interrupting, but I hear that the audio is not accessible for our interpreters. Could you try opening your computer or speaking?
Let me check if this.
I think it has. Is the audio better this way? Yeah, I realized that I'm very sorry, my system went to my computer microphone and not the one which I have on my webcam. So I hope that's better now. Okay, let me just then summarize very quickly. So this slide really shows our initial effort to prioritize populations for vaccination here for community transmission, looking at different vaccine supply scenarios. Most countries, we need to acknowledge, are today still in stage 1, which is very limited vaccine supply. And the priority here, what you want to achieve with vaccination is obviously the direct reduction of mortality and and severe morbidity, and to preserve the most essential services, which are here the health services. Therefore, to start with the health workers, that were those that are at very high risk of exposure, and then the older adults, because it's the risk of severe disease and death is overwhelmingly highest in those. Stage 2 goes then in other groups, older adults, groups with comorbidities, and other groups in the populations that are at much higher risk of disease and death, including then also going to other health workers, and then going also to other groups, employment groups, which are really important, such as priority teachers. So this is just really in a nutshell the roadmap that we have put out to prioritize, and we apply this roadmap clearly to the vaccines that we have reviewed and on which we have issued interim recommendations. If we go to the next slide, this is really just a snapshot of the vaccines that we have so far reviewed and have issued interim recommendations. So we have the 2 mRNA vaccines, and we have 2 vectored vaccines. And obviously we have other vaccines that we are in process of reviewing and should be coming forward soon. And I can speak to this in a minute if this is needed. I think in terms of the recommendations, obviously the vaccines are different, but in terms of the recommendations, as you see here, they're very similar in terms of target populations. And we have grouped, when you look into our interim recommendations, we have grouped the populations by those where we have really very robust data from the clinical trials. And then we have also grouped those where we have very limited data from the clinical trials, but where we nevertheless, of course, are issuing recommendations. This is, for instance, in relation to pregnant women, in relation to breastfeeding, in relation to persons with compromised immune systems. We have fairly little data. I mean, now data is coming in observationally from the use of the vaccine. And we have recommended the use of the vaccine if these individuals are at high risk and with some level of individual information or counseling. Persons with comorbidities were all included in the clinical trials. Normally, you could not really do a detailed analysis by type of comorbidity. This has been kind of lumped together, but there is robust evidence, I think, available from the clinical trials. Now, much information is coming in addition from observational studies. So this is something that is going on and is truly important. There's big differences between the vaccine, obviously, in relation to the storage requirements and handling. I'm not going into this here, and I think many of you are greater experts than I am. One thing which I would just like to say, it's not on the slide, is a word of caution in relation to comparing vaccine efficacy. The vaccine efficacy, as it has been determined in the clinical trials, is extremely dependent on specific aspects, how the clinical trial, on the way the clinical cases have been defined, on the way the testing has been done, and so forth. So, big word of caution in relation to a direct comparison of efficacy between the products. And I think that's all what I wanted to say as a brief introductory presentation. Thanks.
Wonderful. Many thanks, Joachim.
Yeah, and here just last slide. This is, so to say, this is if you click on this, you get to the website of SAGE, and you will get there to a site which lists all the documents in relation to policy, recommendations, and other related guidances that we have put out. Thank you.
Wonderful. Thanks, Joachim. Next slide, please. We will now go to Roy, who will be talking about vaccination strategies for people with comorbidities. Over to you, Roy.
Yes, thank you very much, and good day, everyone. I'll be sharing the story of the approach used in Uganda, and I am Roy Mayaga, a member of the Uganda National Immunization Technical Advisory Group, and also a senior faculty at the School of Public Health here in Makerere University in Kampala. The focus is on vaccination strategies for people with comorbidities. Next slide. So as a background, the goals of Uganda's COVID-19 response are threefold. One, to reduce severe disease and death, to sustain the national health system response, and to restore health and productivity of Ugandans, to get Ugandans back to work feeling safe. And vaccination is key, but the available doses under the COVAX facility through which Uganda is getting most of its vaccine are limited. And therefore, the Minister of Health asked us as the technical advisory group to provide advice on what criteria should be used for prioritization. And this prioritization was based on 5 principles guided by the WHO SAGE framework that has been talked about by the previous speaker. And 5 main principles: human well-being, equal respect, equity, especially considering groups at higher risk of severe disease and death, and then reciprocity, people whose work puts them at high risk of infection that is difficult to control, and those who can easily infect others during their work. And then legitimacy, very important, a transparency process that is grounded in evidence with the use of available epidemiological and non-epidemiological data. We therefore present the evidence used to identify high-risk groups, zooming into comorbidities. Next slide. Next slide, please. So we, next slide. We obtained data from a sample of 7,233 COVID-19 positive cases from Uganda's COVID database. And this was obtained from the National Incident Commander's Office. The data was dated September 2020, and this is the data that we analyzed to get the results that I'm going to present next. Next slide. So first, why comorbidities? We analyzed who is more likely to develop severe disease, severe COVID-19 disease in Uganda. And you can see clearly that 2 groups stand out. The age groups are from 30 to 39 to the age groups 80 plus have a statistically significant higher risk of acquiring severe COVID disease, starting from a 3-fold risk in the age group 30 to 39 to a 23-fold risk in the age group 80 plus compared to those who are aged less than 20. And specifically for comorbidities, you can see that people with one comorbidity were 2.5 times more likely to develop severe COVID-19 disease. And those with more than one comorbidity, the risk shot up to 24 times more likely to develop severe COVID-19 disease. Next slide. The next question is, who is more likely to die from COVID-19? And the epidemiological picture was similar. The age group 50 to 59 and above are more likely to die from COVID-19 in Uganda, from a risk of 6 times more likelihood of death in the age group 50 to 59 to 52 times higher likelihood of death in the age group greater than 80. And if you look at comorbidities, same epidemiological picture with severe disease, one comorbidity, 2 times more likely to die, and more than one comorbidity, 33 times more likely to die. Next slide. We then switched to which comorbidities to focus on. Within the COVID data, we are lucky to have had a disaggregation of the different types of comorbidities that the people had. And you can see that diabetes, 8 times more likely to develop severe disease, hypertension, 2.5 times more likely to develop severe disease, and then chronic organ disease, specifically heart, kidney, liver, 2 times more likely, and then other chronic conditions, specifically cancer, TB, but we did not have data on obesity, but it was included presumptively, 2 times more likely to die. Surprisingly, HIV did not give a higher risk of severity of COVID-19 disease. Next slide, please. That was for severe disease, but the same epidemiological picture is sustained for the risk of death. You can see diabetes 15 times more likely to die, hypertension about 4 times more likely to die, and then chronic organ disease and other chronic diseases, cancer, TB, and obesity, 2.5 times more likely to die. But still, HIV does not show higher risk of death compared to the other chronic diseases. Next slide. Next slide, please. So based on this information, this epidemiological information helped to define category 1B of Uganda's prioritization framework, where we said all people aged above 60 years of age and with in very limited doses, and then with limited doses, slightly more doses, all people above 50 years of age. And then more importantly, people of all ages with a high risk defining comorbidity. And which are these comorbidities? People with diabetes, people with hypertension, people with chronic organ disease, especially heart, kidney, liver, and stroke, people with other chronic conditions, especially cancer, TB, chronic obstructive pulmonary disease, and obesity included presumptively, and very importantly, people with more than one comorbidity should be urgently addressed in the vaccination. Next slide, please. So the next question was, how do we find people with comorbidities? The epidemiological reality in Uganda is that prevalence of hypertension among adults is 1 in 4 adults. And prevalence of diabetes is approximately 3%. However, only 7% of people with hypertension are aware of their status. So how do you get the people? And secondly, only 51% of people with diabetes know their status. That is according, all this information is obtained from the National NCD survey that was carried out in 2014 and other focus surveys. The health system reality is that primary healthcare facilities have very low capacity for instantaneous screening and diagnosis of these priority NCDs that we are talking about. But there's also the question of the ethics of action versus inaction after screening. So, okay, if we vaccinate, what of the diseases, the heart disease, the hypertension, and all those other problems in a context where there's low capacity to manage the diseases and the lack of basic drugs, chronic care clinics, and systems for follow-up. And the implication on the large numbers who would get a first diagnosis of diabetes or hypertension without a support system in the event that we did mass screening to identify these individuals. Therefore, next slide, we provided a conclusion, a recommendation on this. So the NITAG recommends that the focus for vaccination of comorbidity groups should be on people whose chronic conditions are known and are therefore managed within the healthcare system. People who have been registered in a health facility with a diagnosis of any of the conditions specified in this presentation, diabetes, hypertension, chronic organ disease, or other chronic diseases that are indicated, or people who have previously been told by a healthcare worker that they have any of these conditions. And the lowering of the age cutoff from 60 to 50 will also cater for many with silent undiagnosed comorbidities, because we also know they follow an age pattern. With this, mass media drives are needed to mobilize people in this category to visit the designated health facilities for vaccination. And these communications should provide clear justification why these individuals have been identified. And healthcare facilities should also identify the chronic care patients in their records, in their treatment records in their chronic care clinics, and reach out to them through the regular chronic care clinics and through community healthcare workers, a cadre that is highly available in Uganda's communities. And it is also important to concurrently address the high levels of vaccine hesitancy in the population, especially as we address this group. Next slide, please. So these are the technical recommendations that are evidence-based and based on the data that was accessed from the National COVID database regarding how Uganda went about selecting the priority groups for comorbidities to address and how we shall find them in the communities and vaccinate them. Thank you very much for listening to me. Over to you, moderator.
Wonderful. Thank you so much, Joy. We'll now go to Titi Lope to talk about vaccination strategies for pregnant women.
Thank you so much. Can you hear me okay, Shoshana?
The sound is very, very low. Can you kindly speak loudly or open your computer or try and speak louder?
Okay, is this any better?
A little bit, but if you can make it even louder, that would be really fantastic.
Okay, hang on. Sorry, let me just remove my Bluetooth. Let's computer. Is this any better?
Oh, that's perfect.
Okay, perfect. Okay. Sorry for technical difficulties. My computer died on me this morning, so I had to use my work computer and my personal computer. So good morning, everybody. Good afternoon, good evening, wherever you are. My name is Titi Lope Oduyebo. I'm an OBGYN medical officer in the U.S. Centers for Disease Control Prevention, or CDC. I'm on the COVID-19 response and also on the ACIP, so the Advisory Committee for Immunization Practices, COVID-19 work group. So that's the group that makes recommendations and provides guidance related to vaccines in the US, and in this situation, COVID-19. I'll be speaking with you today, and thank you so much to the ECHO organizers for inviting me for this important webinar. I'll be speaking with you today about vaccination strategies for pregnant women in the United States. Next slide, please. So this is not, and I'm sure not new to many people, but just to set the stage of what our recommendations are and why we made our recommendations, especially for pregnant women. As we all know, and not unexpected, given the physiologic changes in pregnancy, that pregnancy increases the severity of COVID-19 illness. It's been over a year now, and we have more data to show that. What I want to highlight today is the leaving systematic review by Alote et al. From the Birmingham group, which I'm sure many of you have heard, and maybe you have participated and have your studies included. What I would like to highlight today is, compared to non-pregnant people, pregnant people are at increased risk for severe illness from COVID-19, as well as death. When you look at what exactly, the severe illness is, their increased risk for admission to ICU, maternal death, and then also increased risk for preterm birth. There is emerging data showing that there's an increased risk for stillbirth, although, the numbers are small and it's a rare outcome depending on where you are. And there's also increases for neonatal intensive care unit admission, NICU. Next slide, please. So specifically for COVID-19 infection, so we've established that there's increased risk during pregnancy for COVID-19 illness compared to non-pregnant people. That said, this the risk, absolute risks are low, but it is still there. Now, related to COVID-19 vaccines, what do we know about the data for COVID-19? So as Dr. Hakam, forgive me if I'm pronouncing your name, but the first speaker showed in that his table where he showed those 4 vaccines that WHO have recommendations for. There is very limited data that we know right now for COVID-19 and vaccines. That said, there is emerging data coming up about the safety profile that I'll go a little bit into. But specifically before CDC made the recommendations, there were no safety concerns in the animal developmental and reproductive toxicology studies, from the Pfizer, Moderna, and Janssen. So those are the 3 vaccines right now that are authorized under the EUA, so emergency use authorization by the FDA and recommended by ACIP in the United States. Pregnant people, were excluded from the trials. For those people, sorry.
Tita Lupa, can you speak just a little bit more slowly for our interpreters?
Oh, sorry. Okay, sorry. Okay, so limited safety data for COVID-19 vaccine in pregnancy. DART studies for the 3 authorized vaccines showed no concerns. persons who were inadvertently exposed, or because we know pregnant people especially were excluded. That said, some people got pregnant, were pregnant and very early, or got pregnant, shortly after. Thus far, there have been no safety concern, but very small numbers. When we look at, now the biology, right, of how this vaccines work, so the mRNA and the adeno-vector vaccines, mRNA vaccines degrades quickly. It doesn't enter the nucleus of the cell. And then for the Janssen adenovirus vector has been used in, over 1,000, I think close to 2,000 pregnant people in the setting of other vaccine platforms that uses a similar platform. So for example, the Ebola, and that hasn't shown any safety concerns. So next slide, please. So putting all this data together in terms of the increased risk, the limited data, yet nothing concerning, and the current pandemic. The US ACIP, which is the Advisory Committee on Immunization Practices recommendation, right now has that pregnant persons may choose to be vaccinated. The goal of this of the recommendation was not to withhold the vaccine from a pregnant person because of their pregnancy status. That said, right, this has to be put in context, which we'll go into, particularly about the limited efficacy and safety data. Definitely, as Dr. Hooker mentioned, a discussion with the healthcare provider can definitely help them make pregnant people make an informed decision. However, in the United States setting, it is not required prior to vaccination. Next slide. Next slide, please. So in the United States, now this graph I want to show in terms of the access, where pregnant people have access, and from the time the COVID-19 vaccines were authorized to now, the access to pregnant people have increased, right? With the initial allocation when there was limited supply, there is still limited but increasing. With pregnant people were able to get vaccinated if they were in a group, right, that were recommended for early allocation, like phase 1A for us here was healthcare personnel and those living in long-term care, facility. And as there be more vaccines, the priority groups have opened up, and some states actually have pregnant people as a priority group. So most states is like phase 1C, if we want to equate it to some of the framework that some people have already talked about, like the Uganda framework or so forth. So phase 1C. And so what you see on this graph here, the states highlighted in blue are the states where pregnant persons have access to it before the general population, because they are, the pregnancy status is considered a risk status because of the observational data that we've talked about. Next slide, please. So as I discussed, the ACIP recommendations are, pregnant people may choose to be vaccinated. And we know that there's a lot that goes into that, that decision, given the very limited data that we have about safety as well as efficacy. And some of the things that, pregnant people are encouraged to think about and to discuss with their healthcare personnel or provider is to look at the individual risk of acquiring the virus, both, for community transmission, as well as, the exposure level, which is usually based on the occupation, the ability to be able to telework, and so forth. The risk of COVID-19 and the potential risk to the fetus, which, we've quickly touched on. The efficacy of the vaccine. So there aren't any specific data right now about the efficacy of the vaccine in pregnancy. That said, the vaccines in non-pregnant people are pretty high, and the expectation is that it will be similar. And I know there's a lot of studies going on in countries, and including the US, related to being able to look at the vaccine effectiveness in pregnancy. Definitely knowing the known side effects of the vaccines. And so we know, the known side effects in non-pregnant people, and the emerging data is showing that, and which, I'll talk a little bit more about. Emerging data is showing that the side effects are similar in pregnant persons. And then the big critical thing, right, that everyone always asks, and very important, especially in pregnancy, is the, safety data, and, making that decision in setting of there's emerging data, but still not as robust as we would like. Next slide, please. So CDC, one of the things that we're working on, and I'm also one of the medical leads for, is a program or a monitoring system called the VSafe After Vaccination Health Checker. And this is one of the systems, it's a new system that's put in place to look at the safety of vaccine in pregnancy on a real-time basis. CDC has traditional systems that look at EHR, that is passive or self-reporting, but that usually takes time to come in. So this VSafe After a Vaccination Health Checker is a text-based checker where people who have gotten the vaccine are informed about VSafe, about this monitoring system, and it's a volunteer enrolled. If they do enroll in it, they get a text message that is linked to a web survey where for the first week, so you can see number one there on the left side, so they get a text message check-ins from CDC. It's daily for the first week, then weekly for the first 6 weeks after vaccination, then 3 months, 6 months, and 12 months after. If it's a 2-dose vaccine, then when they get the second dose, the check-ins reset. So typically, there are questions related to important health impact, like if they've, unable to work, if they receive medical care. And for those people who say that they received medical care, we have a center, VAERS, that will call them to try to get more information about, what the adverse effect was or why they received that medical care, so we can, get some more information about the safety data. Next slide. So now looking at the people who have, voluntarily enrolled and are checking their questions related to pregnancy, if someone was pregnant when they got their vaccination doses, and also if they have got a home pregnancy test or lab pregnancy test, after they got vaccinated. And so, the publicly available data right now, there are 2 places for people to access that. One is through the public ACIP meeting. And as of February 16th, we could see that, people reported that they were pregnant when they got vaccination or shortly after were about 30,000. And this was February 16. As of last week, it was almost close to 70,000, so 69,000 and change people self-identified as pregnant or shortly after they got their vaccination dose, and this number keeps increasing. With Moderna, with the next updates, there'll be another slide for Janssen, because at that time Janssen had just rolled out for the February 6th in 2021, and I will post the link for where we have this number being updated. It's updated every Tuesday, so it'll be updated today with like Monday's number. So this number, when you go to the CDC webpage, will definitely be higher. Next slide, please. Now for the pregnancy registry, right? So that first part that I mentioned for the VSafe checker was really for anybody, right? Pregnant or non-pregnant. And then we identify pregnant people from there. Then there's an extra arm that I work closely with that reaches out to people who self-identify they're pregnant. We want to, first confirm that they are really pregnant, because sometimes people make mistakes, when they put that information in through their, smartphone. And then we ask them questions related to your pregnancy, specifically once every trimester. Then, after the pregnancy outcome, so if they delivery 4 to 8 weeks after delivery, and then we follow the infant, not for long, but up to 3 months. We have other systems, like I mentioned, established system that will follow the infant out for a year. Next slide. And so data from the VSafe pregnancy registry, this was similar to the other was from the last public ACIP meeting. At that time in February, we had about 1,800 plus enrolled. As of last week, Monday, we had close to 4,000, and the number that you'll see today is 4,000, and I believe 300 or so numbers. So there is some lag, right? Because you see in the main VSafe, we have such a big number, and then in the pregnancy registry, there are a bunch of reasons why there's some lags, and we can go into that in the Q&A session if you'd like. To date, from the 275 completed pregnancy at that ACIP meeting, there were no safety signals. That said, to be completely transparent, those were pregnancies, right, that got vaccinated in the 3rd trimester. And I know, the concerns of miscarriages, congenital abnormalities are more for pregnancies that are, vaccinated earlier in the pregnancy. And so, that information is still yet to come. Next slide, please. So there's also emerging, in terms of emerging data, some of the questions and the questions and considerations when a pregnant person is talking to a healthcare provider or trying to decide to get vaccinated is, if, like with maternal immunization, does that protect the infant as well? And also with breastfeeding, is there transfer of that antibodies to breastfeeding? There are emerging studies now. The biggest one that just recently came out last week, Monday, in the AJOG, showed that when they compare pregnant to non-pregnant persons in terms of their immunogenicity, it appeared very similar. Side effects appeared similar. And then also in the pregnancies that were completed, a small amount, they were able to see in the umbilical cord that the antibodies were also were present. So indicating that, there was transplacental transfer as well as in the breast milk. So this is very promising. We still don't know, what does that mean exactly in terms of the immunity and protecting the neonates. Our hope is that, similar to other vaccines, it will protect, but the verdict is still out, and there's more studies on with that. Next slide, please. So some of the common questions, that would come up in terms of vaccination during pregnancy. This is just a list here. We can talk a little bit about, but I'm sure many people are getting these questions as well. CDC has a web page where we have information for the general public with some of the answers for this question. Next slide. Next slide, please. And last, I just want to also show we have some resources for general public, but also for healthcare providers, public health practitioners, to help in terms of strategies to decrease, vaccine hesitancy, to get information out there for people, including pregnant women, related to, information that we know about the vaccine now. Next slide. So I just want to say thank you so much for your time. And once again, I apologize for the technical difficulty, and hopefully you're able to hear me. And I speak slowly so that it could get interpreted. Thank you so much. Over.
Wonderful. Thank you so much. I see, before we go to the next presentation, there's a couple of questions of folks asking how to mute the original language. You can do this by clicking on interpretation at the bottom and selecting mute original language. I'd also ask our presenters, as we're going through the next presentation and the Q&A, to please look at the Q&A and respond accordingly to the questions that are there to make sure we can maximize our opportunity to answer all the questions folks on the line today. With that, I'll now turn to our final presentation on vaccination strategies in humanitarian settings. Over to you, Eva and Alejandra.
Hi, good morning, good afternoon, good evening, everyone. My name's Eba from the Global Health Cluster, and Alejandra will be joining you from WHO later on in the presentation. Next slide, please. So this presentation is about vaccination in humanitarian settings. So I just want to drill down on what a humanitarian setting is. There are vulnerable populations in many countries which are affected by disaster or conflict, but we're really just going to focus on the countries that are defined in the global humanitarian overview, where countries have been identified or have requested international support. Now, within that, there's 56 countries, as you can see here, and 235 million people have been identified through assessments of being in need of critical assistance. Next slide, please. So the health cluster with whom I work works in 30 of these countries and supports 200 million. So the vast majority of the people who are affected. And as you can see in this graph, about 70% of these countries have actually started vaccination campaigns or have vaccines ready in their country to begin. Next slide, please. So some of the key messages that we are emphasizing for these countries in humanitarian settings is that really national authorities are responsible for the provision of services, any service, to everyone who resides in their territory. And this actually really supports public health principles that all populations should have access to COVID-19 response care, as well as vaccinations to reduce death and disease burden, because as we all know, no one is safe until we are all safe. So what does that really mean? That means IDPs, refugees, returnees, migrants, whether legal or illegal, not documented, stateless persons, people living in occupied territories, etc., but also those who are living in hard to reach areas. And this is a really tricky one, whether it's geographic or due to insecurity, but including areas which are not actually under the control of the government. So we estimate there's about 60 to 80 million people that live in opposition controlled areas. Now, there's lots of things here that I could go through with regards to what this really means to reach these populations, but I'll just go to the third to last bullet on the right of what we really need to be people to be thinking intentionally to reach these groups. And that is making sure you understand how to reach these groups when it comes to vaccine delivery strategies. Are you using mobile clinics? Are you using outreach programs, outreach workers, community health workers? Are you camping out overnight in hard to reach areas, which some countries have actually defined? What's the cold chain capacity like to reach these populations who are often hard to reach? The risk communication and social mobilization that go around that. What are these specific intersecting fears and needs that they have? How are you monitoring? Are you ensuring you're monitoring vaccine equity? How are these populations actually able to report any side effects or any adverse events, given that they're often marginalized? So next slide, please. So I'm just going to focus on really what the crux of campaigns are focusing right now, as has been highlighted throughout. In these humanitarian settings and countries, it's really about the first 3% or the first top 10%, where because the vaccine availability is so limited. And what we know from coronavirus response in humanitarian settings is actually healthcare workers have their own specific needs, but they're often overlooked because they're actually the providers in the response, but they are actually a unique group who are affected also by COVID-19. So messaging is needed directly for healthcare workers. There's often delays in technical guidance reaching healthcare workers, and this is the same for vaccines. So often misinformation and disinformation is what they receive first, and unfortunately they themselves transmit on. So healthcare workers themselves have intersecting needs and are often from the populations of concern. We have community health workers who are IDPs, who are refugees, who live in insecure areas. So they have not only their fears around being a healthcare worker, but also their existing vulnerabilities. So fears include, transmitting COVID-19 to not just to their patients, but also their family and community, resulting stigmatization. And of course, as we've seen during coronavirus response, unfortunately, there's been an increase in attacks against healthcare workers. Next slide, please. So the point is that we really need to think about who we're trying to reach and how we are trying to do it. Some of the emerging challenges that we've seen from the countries that have started vaccination campaigns is actually there's not enough time for community mobilization. Often there have been very short vaccination expiration dates. Some have to be used by June or July indeed. And indeed, as highlighted, there is vaccine hesitancy amongst healthcare workers as well as the population, whether they have fears about the vaccine itself or a feeling that COVID-19 is not a threat. Likewise, there's also documentation is often needed to prove residence to be able to be eligible to receive a vaccine. So we know that's going to cause exclusion, and we have to think innovatively about it. As well as reaching insecure areas, we already know there are some black holes within countries where there is conflict-affected populations. So there's emerging good practice there, but I'm just going to move on to the next slide, which is a good practice indeed about Iraq. So next slide, please. Iraq has started their campaign just a few weeks ago, and indeed they are prioritizing healthcare workers and those who are older, as well as those with comorbidities. Right, this seems to be an offside. Thank you very much. And as you can see, they've actually done quite well. First dose, about 80,000 people have received the dose. And 70,000 have actually received a second dose. But if you look on the right, there's actually the vaccine landscape is quite wide. There's Sinopharm, which is being used, as well as AstraZeneca. But we also know that other vaccines, such as Pfizer and Sputnik, is going to be procured as well. So there are some complexities around what vaccination means. Next slide, please. A good example, however, about vaccine equity is indeed Iraq Ministry of Health, and that, as you can see, they are actually monitoring IDP and refugee uptake. And yes, it's quite low at the moment, but they haven't actually started their campaign for IDP camps, which is the next step. But it is actually very good to see that even in the monitoring, they're thinking about vaccine equity. So next slide, please. Some of the successes that we're seeing is that, yes, there's technical bodies correctly involved in the rollout and the planning. There is good training around pharmacovigilance. Digital platforms have been very useful, not just for registration, but also for monitoring, as you've just seen. And the government are very committed to procuring vaccines through various channels, COVAX being one of them, donations and bilateral procurement also. And as we can see, there's already a commitment to ensuring equity for IDPs and refugees. Next slide, please. However, as I've highlighted before, vaccine hesitancy amongst healthcare workers is present, and especially amongst women, where we've seen quite clearly there is less uptake by women. And there is actually a fear of some of the vaccines or one specific vaccine causing infertility. So there's a lot of messaging that's having to occur around that. Insufficient time for community mobilization, as well as access constraints to reach IDPs. But as described, the next step is for the Ministry of Health to reach these camps and use humanitarian partners to help access them. So on that note, I'm going to hand over to Alejandro Costa, who is from WHO. Over.
Hello, good morning. My name is Alejandro Costa. I'm working in WHO, and I'm the focal point for this mechanism, which is named Humanitarian Buffer. So that's not my slide. Next one, please. Yes, thank you very much. So I will present very briefly this mechanism that has been just approved by the Gavi board, and it will be functional in a month, more or less. So this humanitarian buffer is a mechanism to guarantee or to ensure that all this population that has been mentioned by Eva before will have access to this vaccine. This mechanism is part of the COVAX facility and will represent more or less 5% of the overall volume of this vaccine that is available for countries that has adhered to this facility. Either they are part of the Gavi countries, financed by Gavi, or they are self-procurement countries. So this mechanism is the last resort. We call the last resort. I will explain. This is the when the governments cannot include all the populations that they have in their territory for any reason, because as it was mentioned by Eva, they are in a humanitarian crisis, or they are refugees or internal displaced populations, or suddenly the government didn't include these populations in their national development plans because there is a new situation in the country, civil war or displaced population for any reason, and the plan was approved, but now these populations are not included. These governments or countries or humanitarian agencies working on these settings can apply for this vaccine, which is reserved for this humanitarian crisis. And this vaccine will be on top of the vaccine that has been already allocated to these countries. So the mechanism is very simple. It's just the implementation, the application is very simple. Perhaps the implementation will be much more difficult because the agencies or the countries that are submitting an application should demonstrate that they have the capacity to access to this population. So I think the slide is very clear, but I'm very happy to respond. Just to make it clear as a last point, this mechanism is created to cover this population, but it's not a mechanism that will cover perhaps all the population at risk. So there is a mechanism for prioritization, and there is an interagency setting committee that who's responsible for making decision on how this vaccine will be allocated. There are criteria and there are principles as well to distribute and allocate this vaccine. So over to you, Susanna.
Wonderful. Thank you so much, Alejandro. Next slide, please. Next slide, please. So a quick reminder that the recordings from this session will be available in English, French, and Spanish, and that you can continue the conversation through TechNet and Telegram. As well, a reminder that our next session on 13th of April will focus on supply and logistics for health workers, followed by on the 20th of April, mobilizing financing resources to scale up COVID-19 vaccination at this same time. Next slide, please. We unfortunately do not have a lot of time for question and answer on today's session, but we will be collecting all of the questions in the Q&A and providing those to our technical experts to respond to in written form. They'll then share back to you in a finalized Q&A through the ECHO email system, as well as TechNet, all of the responses to those questions. With this, I would like to say thank you so much to all of our presenters today. Thank you so much to all of our participants, to the ECHO India team, and of course to our wonderful interpreters for this really informative and helpful session. So we'll keep the session open for one more minute so that you can continue to include any of your additional questions in the Q&A feature, and then we will go ahead and close out today's call. Wonderful.
Yes, you're clear.
Okay, folks, I think we can go ahead and close out today's call. And many thanks again to all of our speakers, interpreters, ECHO India team, and others for the great opportunity to provide this really informative piece today. We'll see you next week.
Okay, thank you. Bye-bye.